Thank you, Andreas. First of all, I would like to thank Julien and Sébastien for having me over. This is, of course, a wonderful experience for me and a nice opportunity. Second of all, I'm going to try to stay within the 20 minutes because I already got some comments of Lars because of being a football player that I might be stalling sometimes, so I'll try to go as quickly as I can. So indeed, today we're going to talk about brain neurotransmission during exercise in the heat. So here we see the different topics we're going to address during this talk. I'm going to start by saying that fatigue, of course, has many aspects, and today I will be only focusing on the exercise-induced fatigue, meaning we're not looking at any mental kind of fatigue or something else. And what we know from the past is that quite a nice portion of the fatigue is induced by peripheral factors. I'm quite certain that José, for example, will be telling us much more about it later on today. So I would like to focus more on the central aspects of fatigue. And this all started with the central fatigue hypothesis that was put forward by Newsom and his co-workers in 1987. A very basic overview gives you, this is the situation at rest, as we see here. We have the brain, simplified, of course. And here we have the blood, meaning we have the blood-brain barrier in between. And the neurotransmitter that is supposed to be the most involved is serotonin. So serotonin would induce feelings of fatigue. Now what we know of serotonin is that it needs a transformation from its precursor tryptophan in order to be available. And what we also know is that it cannot cross the blood-brain barrier. So meaning it needs tryptophan, which can cross the blood-brain barrier, to come into the brain and to be transformed into serotonin. Yeah? Now, in order to cross the blood-brain barriers, tryptophan has to compete with the branched-chain amino acids because they share the same transporter. That's one. A second competition is here with the fatty acids to bind on albumin. As is logical, it's only the free portion of the tryptophan that can cross the blood-brain barrier. So this is the situation at rest. If we look at exercise, what is supposed to happen is that there is an increase in the fatty acids, which have a higher affinity for albumin than does tryptophan itself. So this causes that tryptophan comes loose from albumin and becomes freely available. This changes, of course, the ratio between tryptophan and the branched-chain amino acids, meaning that more tryptophan will cross the blood-brain barrier, consequently increasing the amount of serotonin and thus inducing fatigue. That's the general idea behind it. So the question then became, can we manipulate the brain? And there have been some nutritional interventions, for example, when administering the branched-chain amino acids themselves in order to change that ratio. And there have been some pharmacological manipulations using reuptake inhibitors. And that's the second part. That's what I would like to talk to you about today. So what we see here is what happens when we administer a reuptake inhibitor. So the normal situation would be that this dot is not present, so meaning we have the presynaptic neuron that releases the neurotransmitters, which exert their function in the postsynaptic neuron, and the neurotransmitter is not being used, normally or usually is taken up again by the presynaptic vessel. However, that is not possible anymore, meaning more of the neurotransmitter remains available in the synaptic cleft to exert its function on the postsynaptic neuron. So the neurotransmitters we were most interested in are serotonin, dopamine, and noradrenaline. So those are the ones we will be seeing later on in the presentation. This slide I've just inserted because I wanted to show you what the effects are of a certain reuptake inhibitor. So here we used the dual bupropion. It's a dual noradrenaline or dopamine noradrenaline reuptake inhibitor. And through the microdialysis study in rats, we saw that after administration, indeed, here we see the noradrenaline concentration that clearly increased after the administration of bupropion. Also the dopamine administration level, while there was no change in the serotonergic level or the serotonin level. Here we see an overview of different studies. Don't start reading it. I don't think it's even possible to read it clearly. I just want to show you that these are all studies that were performed in 18 degrees Celsius, and that most of them did not really find any significant influence of exercise on exercise performance. There are a lot less studies performed in the heat. So here we see the higher ambient temperatures, but what was strikingly is that there were more significant differences found. So performance was much more influenced in the heat. So that's why we further started manipulating brain neurotransmission under heat stress. And in all of the studies we did, we used trained male subjects. We see the characteristics here. And the experimental design was also the same in every study, so it was quite easy for me. So meaning we start with a maximal exercise test. This was followed by a familiarization trial. And then there were 4 experimental trials, of which 2 were in 18 degrees Celsius and 2 were in 30 degrees Celsius. So this was, of course, randomized. One was with placebo, the other was with the drug intervention. An experimental trial itself consisted of first a 15-minute rest period, which was followed by a constant load trial in which the subject had to perform at 55% of their maximal wattage for 1 hour. That was immediately followed by a time trial to measure the performance. Subjects had to start at 75% of their maximal wattage, and if they remained at that wattage, the time trial would last exactly 30 minutes. Of course, they were free to change that power output, meaning if they decreased it, the time trial would last longer than 30 minutes, and vice versa. After the time trial, there was a 15-minute recovery period. So one of the studies we did was serotonin reuptake inhibition. We administered citalopram to the subjects, and what we see here is the time trial time on the y-axis, and on the x-axis the different trials, so meaning in 18 degrees Celsius and in 30 degrees Celsius. So I will be focusing more on the 30 degrees Celsius trials, since this is a heat conference, of course. And what we saw was there were quite large standard deviations, but the overall statistical analysis provided that there was no significant difference between placebo and the serotonergic reuptake inhibitor, although there was, I think, a 1.5-minute difference between the 2 trials. So another drug we administered, I just told you before, we also did that in the rat studies, was bupropion. And bupropion is actually an antidepressant and also well, kind of often used as an anti-smoking aid, so meaning it will help subjects stop smoking. And just to give you an indication, in 2007 alone, in the US, there were over 20 million prescriptions for bupropion. So we did the same study, and what we saw was that in 30 degrees Celsius, subjects performed over 3 minutes faster when they had bupropion. So meaning they were about 10% faster on their 30-minute time trial, which is quite a large difference. And coinciding with that was that in the bupropion trial, see here, the average core temperature reached 40 degrees Celsius, while in the placebo trial, this was only 39.6 degrees Celsius. So meaning the subjects were much warmer compared to the placebo situation, and they were producing much more power as well. But if we look at the ratings of perceived exertion or at the thermal sensation, we see no difference at all. So meaning they were pushing harder, they were much warmer, they didn't feel it. This indicates that, well, subjects were able to do this without any negative feedback from the central nervous system. So meaning that the safety brake, let's say, did not work. So meaning bupropion allowed them to go harder, to go faster, without any problem. This, of course, begs another question, because what if subjects, well, subjects or just patients who want to stop smoking start taking bupropion while they want to go cycling for their holidays? We'll see that afterwards. Another question we asked was, of course, well, it's a dual dopamine reuptake, noradrenaline reuptake inhibitor. So was it more the dopaminergic influence or more the noradrenergic influence? So we gave them methylphenidate, also known as Ritalin, what we give to children with ADHD. And this is what we found. In the heat, they were over 7 minutes faster compared to the placebo situation. Again, looking at the core temperature, so this is only the trial in 30 degrees Celsius. What we see is here, this is the rest phase before exercise, where we see already a difference. During the 60 minutes fixed intensity trials, there is no difference between the two. But then from the start of the time trial on, we see that the increase in core temperature becomes much greater in the methylphenidate trial compared to the placebo trial. So again, subjects are allowed to go much faster and much harder. and become much warmer as well. And as with the previous, the bupropion study, again, RPE and thermal sensation, no difference at all. So then we also had to try the noradrenergic reuptake inhibition, of course. And here the results were quite reversed. So meaning both in 18 degrees Celsius and in 30 degrees Celsius, subjects were significantly slower when on the reboxetine than on the placebo. Then what we see here is that, well, there is a slight decrease in the core temperature, but this is rather due to the decreased metabolic heat production, of course, is nothing else. So next thing we did, we looked at the pharmacological profile of bupropion. And what we know is that the peak concentration is reached after 2.5 to 3 hours. And we know that hydroxybupropion, which is the major metabolite of bupropion, and which is known to exert a certain noradrenergic effect, only reaches its peak concentration after 6 hours. So we assume that in a first instance, bupropion will predominantly work through dopaminergic pathways, and only in a later stage also through the noradrenergic pathways. So to come back to my question I asked before, what if subjects or patients are taking this drug and go cycling? What we did was we gave it in a chronic way. So we gave them bupropion for 10 days and looked what happened then. What we saw is the performance difference, so the improved performance, the ergogenic effect, disappeared. No more ergogenic effect, and also the increase in core temperature was much less pronounced compared to the acute situation. So again, looking at the pharmacological profile, we were looking for an answer, of course. And what we saw is that after 10 days of administration, the concentration of bupropion remains the same, while the concentration of hydroxybupropion increases a fourfold. So meaning that the participation or the role of noradrenaline probably becomes much more important in this chronic situation, which would account for the fact that we no longer found any differences in performance. Another study we did with bupropion was to look at, because we actually gave the maximal allowed dose, what would happen if subjects took a lower dose? Because, well, normally in a treatment also you don't start with the maximal dose, of course. So what we did is that we gave them also 50 and 75% of the maximal dose. And the outcomes, well, there was no dose-response relationship. What we see here is that only in the maximal, after giving the maximal dose, the subjects were able to perform better. So I would just like to talk to you a little bit about adenosine antagonism. So in particular, we did a study on caffeine. As we can see here, obviously drinking caffeine has some advantages because the other one's already asleep. So mechanism of action of caffeine, of course, is not only in the central nervous system, but also in the periphery. So I would just like to focus on the antagonism of adenosine. And adenosine, of course, inhibits the release of dopamine. So meaning if we block adenosine, probably more dopamine will be released. And here is an overview of quite some studies that already performed caffeine administrations in normal ambient temperature. And what is striking is that, well, striking, no, it's kind of what we all know. Caffeine slightly improved the performance in this normal ambient temperature. If we look at caffeine studies in the heat, however, well, we see that there's quite some discrepancies. There are quite a lot of studies that did not show any significant difference. There were some studies that still found that ergogenic effect, and often they were combined with the administration of carbohydrates. So we did our own study, and again, we did it only in the 30 degrees Celsius mode. And what we saw was that there was no difference or no improvement in performance after caffeine administration. I have put also the time trial times of every individual here, and what we immediately saw was that there were some apparently responders who really improved their performance, while there were quite some others that had even a reversed effect of the caffeine administration, which is quite strange. What we did see was that there was a clear thermogenic effect of caffeine. So From actually the start of exercise on, we see that subjects performed or had an increased core temperature after caffeine administration, and this became even more obvious during the time trial. Also, the skin temperature was significantly, or not significantly, but was, well, as you can see, a bit increased due to the caffeine administration. So, of course, you wondered why is there no difference in performance. In literature, we found, well, some things that might explain this. One of them is the inter-individual changes. So meaning there are some studies and reviews that already mention this, that there are, in fact, responders and non-responders to caffeine administration. There might also have been an increase in the noradrenergic or in noradrenaline, meaning that, well, of course, when we influence dopamine, logically also noradrenaline might be involved or might be influenced. Another factor is that the heat may indeed have negated the efficacy of caffeine. Also, the test protocol could be one of the reasons why we did not find any difference. And lastly, also the elevated body core temperature has been issued before as a reason. However, since we only reached 39.5 degrees Celsius, while in other studies we went quite a lot further, this also seems doubtful. I would just like to show you one more study from Beatty et al. In 2006, in which they informed subjects, so they had to perform 3 trials, and they informed subjects that they would be receiving doses of caffeine, meaning, well, a placebo, 4.5 milligrams per kilogram and 9 milligrams per kilogram, while in fact they got nothing. So they got placebo 3 times. However, they improved their performance thinking they had the 9 milligram dose. So I'm just putting this up because we always have to think about what we are doing and be careful interpreting our results. Another aspect, another very important or interesting aspect is the effect of brain activation during exercise under heat stress. Unfortunately, Kevin doesn't allow me to talk about it here because he will be talking about it in, I think, 2 speeches from now. So he just did his PhD, which involved mainly this topic, so I will let him do the talking. He'll do that much better than I do. So to finalize, I think we showed that there is certainly a central aspect in fatigue, and that we can manipulate brain neurotransmission, meaning we can influence the performance, and this is partly due to the will or the motivation, the drive to continue exercising, to push yourself to the limit. And we've seen that specifically with dopamine manipulation, this is improved, while with noradrenergic, serotonergic manipulations, this is rather decreased. Of course, I also have to thank my promoter, Romain Meeuwsen, who normally does this talk. Well, I'm grateful I can do it this time. But well, he's kind of the man who thought about all this. Thank you for your attention.
Thank you very much, Bart. Any questions?
Thanks very much, Bart. I just want to clarify on slide 21 where you show the study by Phil Watson. Yeah, you concluded that safety break, and you have gone past that safety break. But I saw your core temperature for the bupropion trial in the hot environment was 40 degrees C.
Yes.
And I suppose no participant had any health consequences. I'd like to interpret that maybe the safety break was not ignored. They still regulated well. And you, in fact, had a great advantage when you took that particular drug. In this case, was bupropion. So I somehow interpreted that he still had that safety break, and in this case, your data proved that it was safe and good.
Yes, I agree. Well, I think it's more a general thought. I could give you the example in the methylphenidate trial, so in the Ritalin trial. First of all, we do all our studies having a doctor present, of course, because, well, you never know what happens. But I must say, in the methylphenidate trial, for example, there was one subject that reached, at the end of his exercise, went to 40.5 degrees Celsius, which is really quite high. And yeah, he was starting to see black spots all around. So yeah, meaning this was really, he was going over the limit actually. Even when he sat down afterwards, he even increased his core temperature a bit further. So meaning, yeah, of course, there will be a certain safety mechanism still holding back, but I think I'm quite keen to think that in some cases, it will allow the subjects to go beyond what they are normally doing. So meaning, presumably, they will have a certain reserve capacity at all times. I think the drug will allow them to also use that reserve capacity before fatal collapse, of course.
Thank you. Thank you for staying within the time, so I didn't have to use the red card and stuff like that. But then I have the time for a question. You said that you in the caffeine that you had responders, but couldn't that just be normal variation that you see? Have you actually checked if they were responders?
No, that indeed that.
So that would require.
What we did, we are well aware of the fact that, or we know that they are not regular caffeine users. They were not regular caffeine users, so that's not really an issue. But yeah, no, we haven't further checked on whether or not they are real responders or not.
Another issue could be also that what happens when you take caffeine on cerebral blood flow? That could be an issue.
Yeah.
I mean, we know that it goes down in the heat, and it's probably not limiting performance since the cerebral metabolism doesn't decline. But when you add caffeine on top and you inhibit your adenosine system, then you won't have the vasodilation from adenosine. Then you could have a further decrease in cerebral blood flow. So that could be an idea.
That's possible, yeah. Thank you.
I have one comment and one question / comment. Number one, you could see some of your results as behavioral thermoregulation by limiting central thermosensors in the brain. That could be possibly like in the study that I mentioned earlier with thermal and non-thermal stimuli. You are looking at thermal sort of blocking thermal signals using a non-thermal stimulus. And regarding the non-responders that Lars mentioned, there's some data coming out, I think now or very recently, talking about genetic polymorphisms in terms of some proteins related to caffeine. So maybe you could have you heard about that?
No,
or have you?
I haven't. But I'll check that.
Maybe that's the answer to your data. Yeah.
Indeed.
Okay. Thank you very much for staying on time and.